So the nurse's role in monitoring the lab values really depends on the clinics you're working at, but really when our patients are receiving treatment, especially in the infusion center, the nurses should be looking at those lab values prior to treatment being started. With the advent of the oral therapies, again, a lot of times nurses or even pharmacists are looking at those lab values. Patients aren't having them as frequently as we do when they're getting IV therapy, but they're still getting them, sometimes weekly at the beginning of therapy.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Clara Beaver, Manager of Clinical Education and Clinical Nurse Specialist at Karmanos Cancer Center in Michigan, about the oncology nurse's role in monitoring lab test results for patients with cancer. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome. Thanks so much for joining us today, Clara.
Thanks for having me.
So let's start off today briefly going over a little of the basics. What is the nurse's role in monitoring labs and educating patients about the importance of these labs? And how has that role evolved as our treatment options for cancer care have transitioned from mainly IV administration now into more predominantly oral administration?
So the nurse's role in monitoring the lab values really depends on the clinics you're working at, but really when our patients are receiving treatment, especially in the infusion center, the nurses should be looking at those lab values prior to treatment being started. With the advent of the oral therapies, again, a lot of times nurses or even pharmacists are looking at those lab values. Patients aren't having them as frequently as we do when they're getting IV therapy, but they're still getting them, sometimes weekly at the beginning of therapy, sometimes going to monthly or bi-monthly once their therapy is going on. But it's still important to look at the lab values because much like IV chemotherapy, the oral chemotherapy agents still affect those lab values, and we need to make sure that our patients remain safe.
Absolutely. As we already mentioned, our therapies have changed a lot from sort of your classic chemotherapy, anti-neoplastics, into some of our immunotherapies, our targeted therapies. So which anti-cancer drug classes are most likely to be associated with lab abnormalities?
Your traditional chemotherapy agents are the ones that we see the most lab abnormalities with, and we can predict those a little bit more. With the advent of more of the advanced targeted therapies and immunotherapies, we still see lab values that are altered because of the way that the treatment works, but they may differ a little bit than what we traditionally saw with our normal chemotherapy agents.
Great. Well, thank you for that. Well, now let's talk a little bit about what these lab values are that we're monitoring. So let's start off with our old favorite, the CBC, or the complete blood count. When would it be ordered with differential? We sometimes hear it say with or without diff. What does that mean?
So the differential really looks at the white blood cells and what the uptake of the white blood cells are. So as we know, the white blood cells have eosinophils, basophils, neutrophils, and we're really looking at those neutrophils to make sure that our patients can receive treatment because the neutrophils are the ones that fight infection. So for example, a CML patient may have a very high white blood cell count, but the white blood cell count may be leukocytes or other things that are in there, not necessarily neutrophils. So it's always important to wait for that differential to make sure that our neutrophils are in the right area for us to be able to give treatment.
Another component of the CBC is the hemoglobin. What is hemoglobin and why do we monitor that?
So hemoglobin is also known as a red blood cell count. And the red blood cells or the hemoglobin are the blood cells that carry the oxygen through your body. And we really want to make sure that we monitor that to make sure it's not too low. If it gets too low, the patient can have anemia, and then we may need to give them a blood transfusion to correct that count. Another thing you can look at in the patient is that the patient often complains of feeling tired or out of breath when their hemoglobin is low. I think it's also important to remember that as we talk about all of these, that the lifespan of the actual cells. So the lifespan of a red blood cell is 90 to 120 days. So it's usually not one of the first things that we see dip or get low when the patient's receiving treatment.
And how about platelets? What are platelets? Why do we monitor them? Why are they important?
Platelets are part of that blood count that helps us form clots when we're bleeding. So if a patient has a too low a platelet count, they're at a high risk for bleeding or not clotting. It's important to monitor our patients for that. Sometimes we see symptoms with our patients of pinpoint red spots on the skin called petechiae. That's usually one of those clues that like, oh, I really need to look at the platelet count to see what's going on with them. And again, if their platelets are too low, they're not going to be able to stop bleeding. So they may complain of like increased nosebleeds or a cut that just doesn't stop bleeding. And the lifespan of platelets is 8 to 10 days, but they stick around a little bit longer. We make about 10 of them a day. And what they say is in about 2 days, your platelet count can be replenished if it decreases. So platelets is usually one of the cells that I see drop last. It's not one of the first cells that I see drop.
And then we already briefly mentioned neutrophils, but what are neutrophils? How do we monitor them? And when should we expect them to drop?
They're the white blood cells that help fight infection. I always call them when I talk to my patients like a little bus that goes out and sees what shouldn't be there in the body, picks them up, and then gets the rest of the immune system in to help us understand that there's something there that needs to be fought off. It really is our body's first line of defense. So if they're low, they can really reduce our risk for fighting infection. We look at them usually prior to treatment, and then sometimes, depending on what's going on, 7 to 10 days after, or more frequently if the patient's starting to complain of issues with infection. Now, I talked about the lifespan of all the other cells, and neutrophils are usually what stop treatment. And part of that is that the lifespan of a neutrophil is 48 hours. It is proliferated very frequently in the bone marrow, but that is usually what we see, the cells that we see that stop treatment.
And as you mentioned earlier, classic chemotherapy, really the types of treatment that historically we've been given and we have given to patients, and we've seen those blood counts really significantly impacted. The neutrophil count is something that we follow pretty closely for that. So that certainly makes sense. We talked a little bit about ordering a CBC with differential. What are the circumstances when a nurse would need to manually calculate a patient's absolute neutrophil count?
So the absolute neutrophil count is actually what we want to look at, right? So again, I talked about you don't want to just look at what the white blood cell count is. And usually your lab will calculate that for you, and you'll see it says ANC. That's what we are always looking for. But occasionally the system may not be able to do that, or if they are doing it by microscope and they don't have the computer software to calculate that for you, you're going to look at the segs and the bands within the neutrophils. You're going to take your segs and bands, you're going to add those together, multiply that by the white blood cell count, and divide it by 100, and that will give you your percentage of actual functioning neutrophils, the ones that we want to help fight that infection.
That's really important. Again, as you mentioned, a lot of it has to do with the equipment, the technological capabilities of the lab where the test is run. And so it is important, even this day and age with computers in our pockets at all times, to still have to know the calculation to do that manually, because you just never know. Equipment can go down. You can have downtime, and then all of a sudden you have to pull all that knowledge out of the back of your brain. So it is important to remember that.
Yeah, and it happens more frequently than we would like. So
Absolutely.
It is good to know how to do it.
Yes. And then finally, related to neutrophil count, what is a nadir and why do we look at this?
So nadir, in the traditional sense of chemotherapy, as really any of the therapies, is when your blood counts get to the lowest possible point. In traditional chemotherapy, that usually occurs about 7 to 10 days after a patient has received treatment. Again, depending on your treatment, the nadir can change. Some of the pegylated and some of the immunotherapies, you may actually see your nadir is much later based on how the agents are working within your body. It's good to tell our patients when we would expect that those blood counts get low, because then we're going to teach them things like making sure they wash their hands, stay away from people that have infections, watching for bleeding, or that feeling tired. There are a lot of advances in supportive treatment, including pegylated growth factors that help us keep patients out of those really deep nadirs that we used to see a long time ago. And the nice thing about the pegylated growth factors is they kind of sit in the bone marrow and they work when they need to be working. So they start to tell the body when they need to produce those. So they kind of monitor what's going on and then help the neutrophils pick up when they need to pick up. So when we don't see as many being produced. So I think that's a great advancement that we've seen since I started giving chemotherapy many, many years ago.
Absolutely. As you mentioned, educating our patients and their caregivers about what the concept of a nadir is and when their counts will be what we think be their lowest and kind of how they'll feel around that. It lets them know what to expect. I think some patients they think, well, as soon as that treatment hits my bloodstream, I'm going to feel terrible. And as we know, hopefully not. We've got a lot of great medications that can help hopefully prevent many of those side effects, but there is sort of a natural course of what their body will kind of go through in terms of replenishing those blood counts. And so giving them that foresight to say, hey, in about 8 to 10 days, or if it's 12 to 14, whatever the drug is, that helps give them sort of an explanation of like, if you feel a little bit tired, this is probably why. And so I think that does give them a little bit more reassurance of if they start to feel worse, maybe a little bit later than they had originally thought they would.
Yeah, and I think it's important to remember that when we're giving chemotherapy, it is attacking those cells at the time we're giving the chemotherapy, right? So usually chemotherapy comes out of your body within 24 to 48 hours. So remember those lifespans of those cells, that's why we're seeing it so much later, right? Because the lifespan of the cells are the ones that are being made in the bone marrow at that time, not the ones that are currently circulating within the body.
All right. Well, now let's talk about another common lab test that we often order for our patients who are receiving treatment, the Comprehensive Metabolic Panel, or often called a CMP, maybe a BMP if it's not fully comprehensive, which includes chemistries. So let's talk about that lab test and what it evaluates. What do we look at for liver function tests as part of that CMP?
Liver function tests really help us determine what's going on with the liver and if it's clearing the bilirubin or any other blood waste products appropriately. So what we really look at is the ALT, which converts protein into energy for the liver cell. So if those are low, we know that there's some issues with clearing. The AST, which is an enzyme that helps the body break up the amino acids within our system. So again, if that's high or low, we need to see what's going on with that. ALK-Phos, which is an enzyme found in the liver and bone that helps break down proteins. We need to look to see where that's at. Albumin, which is made by the liver and used to help fight infection. Again, if that's low and we've got neutrophils that are low, we need to make sure that our patients are being protected. And then finally, bilirubin is another one that we look at, and the LFTs. And that's really that substance that is produced when we're breaking down red blood cells. A lot of times we'll see that the bilirubin is elevated after some of our agents, and that's partly because of the way that the agents are working. So we just need to make sure that we keep looking at that bilirubin, making sure it's not getting too high, which if it does get too high, sometimes you see yellowing of the eyes or the skin, and then that tells the physician on top of the bilirubin level that we need to do something else for the patient.
Moving on, we also look at kidney function as part of a CMP. What parts of this test help us evaluate the kidney function?
So kidney function, or it could be called renal function tests, are really to determine whether the kidneys are functioning the way they should be. So we look at an estimated glomerular filtration rate, or GFR, which is really based on the patient's protein level, their age, gender, and race. And the test really looks at how efficiently the kidneys are clearing the waste from the body. So that's really one that we need to look at, especially as we're giving agents that are excreted through the kidneys. We want to make sure that their kidneys are working appropriately. The blood urine nitria, or BUN, measures the nitrogen made from the protein breakdown that's really concentrated in the blood. So again, we don't want to see that too elevated because that means that we're not excreting them appropriately. And then serum creatinine measures the amount of waste produced from muscle tissue breakdown and what's called creatine, and that's what's circulating in the blood. Again, if we see a high level of that, we need to make sure what's going on and whether the patient is actually getting rid of that breakdown through the kidneys as it should be.
That's great. All these tests, we see them so often, and every time we review these reports, we see them. And as long as they don't look elevated, I think it's easy to kind of just breeze past them because there's nothing wrong. But it is really great to kind of talk about them one by one to really kind of remember what it signifies. And so when we do see these results abnormal, that we kind of connect them to what could be the underlying problems. This is really helpful. Let's talk a little bit about fluid and electrolytes that we see in a CMP. What can we learn about maybe a fluid balance or the electrolyte balance based on the results of a CMP?
So as you remember from basic biology, my son is in that right now, so I'm learning it again.
Relearning it, yes.
Yes. Electrolytes are really the minerals in our body that have that electrical charge when they're dissolved in water and body fluids. And they really help our system stay balanced. It helps support muscle and nerve function. And so when any of the electrolytes are out of balance, you can see out of balance of the rest of them. So I remember back in college biology when they talked about how the sodium channel blockers and the sodium channels opening. And if it's, I just see that picture in my head every time I think about electrolytes. The electrolyte panel can include many things, but things like sodium, which really control the fluid in your body and really helps the nerves and muscles work properly. And again, we know if we have too much sodium, sometimes we have increased blood pressure, we have increased swelling, because again, that sodium is really what's supposed to be there to help us balance all of that. Chloride, which controls the amount of fluid in your body and helps maintain the healthy blood volume and blood pressure. Potassium, which helps our cells, heart, and muscles work properly. Again, we know if there's an elevated or too low potassium, that we have to make sure we're watching our patient's heart to make sure that they are not having arrhythmias and making sure that we can, again, correct those balances. Bicarbonate, which really maintains the acid balance and plays an important role in moving that carbon dioxide out of our blood system. So again, if the bicarbonate is too high or too low, we're going to have to figure out how to adjust that to our patients so that they can, one, get the carbon dioxide out, but also make sure we don't have those shifts in our other electrolytes. Calcium helps with the bones and teeth, but also, as we talked about a little bit ago, really helps a role in heart function. And depending on where your calcium, your sodium, or your potassium is, you can have heart arrhythmias. Magnesium helps the muscles and nerves and heart function properly and control blood pressure and blood glucose. So again, making sure we're looking at that magnesium level and making sure that it is appropriate for our patient. And then phosphorate, which works together with the mineral calcium to help build bones. And like I said, if there's an imbalance in any of these, it really causes a shift of the other ones to help the system of your body keep working. So that's why we keep a really close eye on them and try to make sure that they maintain the levels that they should.
Wonderful. And then last but not least, as part of the CMP, we also typically measure glucose. So talk a little bit about why we measure glucose.
Glucose, as we all know, if it's elevated, it really shows that we have diabetes or something going on with maybe our spleen or our liver or something else is going on and the body is not absorbing or taking care of the calcium the way it should. And some of our treatments and supportive care is like if we're giving prednisone for our CHOP, may increase that glucose. So it's really important for us to watch the glucose level of our patients. If we see an increase, see what else is going on with them. We may need to do a fasting glucose if the patient has relatively high over a period of time. Again, we just need to make sure that we monitor that. And then if they continue to have high, make sure that we start them on some type of treatment to help bring that down. Nobody likes to have a high glucose or low glucose. You know, people that have low glucose often pass out or black out or don't feel well. And people that have hyperglycemia can actually end up in the hospital in diabetic ketoacidosis. Again, messing with all those electrolytes going on in our body.
And, it strikes me as you've talked through all of these very interesting, very important components of the CMP is our patients come to us with existing comorbidities, other conditions that affect these numbers. If they have, already existing kidney disease, liver disease, diabetes, as you mentioned. So not only is it important for us to watch these week or month over month as patients are going through their treatment for their cancer, but acknowledging that they might have a baseline abnormality that we also will have to monitor, but kind of care for collaboratively with their other specialists that they're being seen by. So it just adds another layer of complexity, and it's what makes oncology, I think, so interesting and unique.
Agreed.
Well, let's talk a little bit about kind of how often we're doing these tests. How do the tests or the monitoring intervals differ depending on the type of therapy that a patient is receiving?
So again, it's still evolving, right? Everything is different. So for your traditional chemotherapy, you usually have labs drawn at least 7 days before you're giving chemotherapy. We're drawing them usually at the start of every time that they're coming in. So not even the start of every cycle, every day that they're coming in. So whether they're coming in day 1, 7, and 15, we're going to be drawing those labs prior to make sure that we can give chemotherapy. With some of the immunotherapies, it may not be as often, every month or every other month. Some of the targeted therapies, because again, we're really targeting that agent, you're not going to see it as frequently, but we're still watching those labs. Now, most of our medications or treatment options nowadays have multiple different lines of therapy. So they may be getting traditional chemotherapy and immunotherapy. They may be getting a targeted therapy, immunotherapy, and maybe a chemotherapy agent. So really, we have to look at what's going on with all the things that they're receiving and determine what their blood count should be. We want to make sure that we're taking them pretty soon before they start therapy. If I took their blood count 14 days before I started a chemotherapy agent, their counts could have changed in that amount of time. So sometimes physicians like to see them 24 to 48 hours before treatment, sometimes 7 days. It really just depends on what's going on with the patient and the agents they're receiving. We talked a little bit about oral agents already. Again, depending on the oral agent, it could be weekly when they first start and then go to monthly or bi-monthly. It really just depends on what oral agents they're receiving and what else is going on with the patient. We do see now where a lot of patients are getting oral agents and traditional IV chemotherapy. And so their labs are getting drawn a little bit more frequently. So it just really depends on what's going on with the patient and the treatment they're receiving.
Just reminds me of patients who don't live, just next door to the cancer center or the infusion center where they're coming. And so the notion of getting labs ahead of time was sometimes complicated because they wanted to try to shorten their stay when they were coming for treatment. So they wanted to get their labs drawn ahead of time. But then if it was a third-party lab, you had to track them down. That's the complexity of our healthcare for our patients, of just trying to facilitate that aspect of care, because you're right. They do need to be relatively close to when the therapy is going to be given so that we have as accurate of a result as we can. But certainly there are accommodations that we try to make for our patients to help make their day with us more efficient, maybe a little bit shorter if we can. And so just some things to consider, even for something that seems as simple as just a quick blood draw. I'm kind of working through all of those other barriers that patients encounter. Another thing that we need to think about when we're drawing are these labs, these blood tests. It's not just the CBC and the CMP that we do pretty classically. Sometimes we are also drawing a pregnancy screening test. Can you talk a little bit about pregnancy screening for patients with a uterus who are of childbearing potential? When are we doing that? How often are we doing that?
If you look at most of the drugs out there, they do say that we should not get pregnant while you're getting chemotherapy. Any of the drugs, actually, any of the treatments, any of the clinical trials, most of them pretty much exclude individuals that are pregnant. So pregnancy testing is important to receive prior to a patient starting treatment. And it's important for the physicians to discuss pregnancy status and remaining not pregnant during treatment. But the nurses, I feel a lot of times, are the ones that really talk that through with the patients and talk about it. The current ONS guidelines state that pregnancy testing should occur before treatment, although there are a few formal guidelines that say really where we should do pregnancy testing. At our organization, we have decided to take the stance that pregnancy testing for patients of childbearing potential, which is defined as when breast buds form in puberty through the age of 50, with the exception of patients that had total abdominal hysterectomies. We do pregnancy testing at the beginning of each cycle or at least monthly for our patients that don't have actual cycles of therapy. We've had a couple instances where patients have told the physicians that they were not pregnant, there's no way they could get pregnant, and then would go for a radiology exam and find out that they were pregnant. So our organization has gone to mandatory pregnancy testing for any patient that has the potential of childbearing during treatment.
Well, that's really interesting. And as you said, I think that it is becoming more standardized. And I think that the most updated ASCO and ONS anti-neoplastic administration safety standards do try to address this more clearly so that there is, I think, a little bit more straightforward guidance for institutions as they try to implement this. And it can be done as part of a blood test. So from a sort of efficiency, a convenience factor, if patients are already getting blood drawn, it can be drawn just along with that. Obviously, there is the option for a urine-based test as well. But as you mentioned, it's just important for your institute, for you to understand what your institution's policy is. And as the nurse, making sure that you're helping to support that. And I think as you mentioned early on, personal opinion inserting here, I think what's even more important is the continued counseling of reminding patients to make sure they're using contraception if they are sexually active. And so the testing, the screening is very important, but that has to be paired along with that constant reminder and reinforcement of that education to use that contraception. And so now we'll move on a little bit into this era of precision medicine and precision oncology that we find ourselves in. It's not brand new that we've checked something called a tumor marker, although now we, I think, are more commonly calling this its true name, which is a monitoring biomarker. So tell us a little bit more about how those types of biomarkers, these monitoring biomarkers, are being used, how these tests are drawn, and how the results are being used in care.
So there's a few different ones, but a lot of the biomarkers are through blood draws. For example, a CA-125 for ovarian cancer. They're very helpful for physicians to monitor the response to treatment or even help with diagnosis with someone that has really benign symptoms and not knowing what's going on. For example, a PSA, which is we see a lot in older gentlemen, but they unfortunately don't tell the whole story of what's going on. So it's a number, but like, for example, the CA-125 can be elevated during menopause. It can be even when a patient is on their period or has some other infections going on. So it doesn't really show the true number of what's going on with the cancer therapy. Now, patients often get fixated on this number. Once, I can remember my ovarian cancer patients always want to know their CA-125 very frequently as soon as it was drawn. My father has prostate cancer and he's always lives and dies by his PSA number. But that really is just a number and doesn't really show what the actual response of the disease is. It does give the physicians an idea of that something might else be going on and to order some additional testing, but it really is just a number. Like you said, with the age of precision medicine, a lot of tumors are being sent for additional typing. They're being sent for cytogenetics. They're being sent for genetic testing. They're also being sent to look to see what agents will work against the tumor better. You'll see that is some of it can be through blood draws, some of it can be through saliva, and some of it, the actual tumor block has to be sent to third parties to take a piece of that tumor and look at what's going on. So again, it just really is a matter of what we're looking at. And every day something new comes out, I feel like. So we're just constantly in this state of figuring out what's the best way to treat our patients and make sure that we can see how their tumor is actually responding.
You're so right about sort of the notion of the tumor marker. And historically, it was kind of all we had. This was before the age of precision medicine. It really was the only means we had without doing, lots of scanning and things to have some sort of idea of maybe what was happening. And so I think it's understandable how patients became very attached to it. I think as clinicians, we became very attached to it. But over time, like you said, we acknowledge that it by itself isn't precisely diagnostic of exactly what's happening. It is an indicator. It can give us trends of if it was high when treatment started and now it's low, that makes us feel like things are going in the right direction. But certainly by itself, standalone, can't tell us everything we need to know. So as you mentioned, important to guide patients and reinforce that with them so that every little blip in that number doesn't hopefully send them into anxiety and panic because, as you mentioned, there are lots of things that could impact how that number trends. And so kind of watching it slowly over time is really the best use of that. Finally, all of these labs we've talked about, depending on what our patient's diagnosis is, what their treatment is, we may see these with different frequencies in our practice. But overall, what are some of the key patient education points that we as nurses should be communicating to our patients about the importance of their labs, how they should interpret these results as part of their care?
I think it's important for nurses to start looking at lab results with their patient very early on, even before treatment starts, so they understand what the normals look like. So when they do get those lab results, because now pretty much everybody has patient portals, right? So the labs are reported in there and they're seeing the labs before they're talking to their providers. So if we can start early on and talk to them about what the normal lab values are, what they mean, and what we're looking at when we're drawing these labs, I think it's really important for the patient. So again, talking about the different parts of the CBC, what does it mean? What are we really looking for? What does it mean if the hemoglobin is, a little bit low, but not too low? If the neutrophils are really low, what should I be doing? So again, I think that education needs to continue throughout their treatment, but really start at the beginning of treatment. What is a CMP? Why are we looking at it? What should highs and lows look like? A lot of the portals will either have red or green or up and down arrows so that they can really tell if they're high or low, but they don't know what that means. And again, if we don't look at the initial labs, how do we know where they're at? Because like you said earlier, a lot of patients come in with comorbidities, and so they may already have a higher creatinine because of some kidney disease that they've already had. So it may be high on that portal, but are we looking at it going down or even higher from where it started? So really just talking with our patients in the beginning and then continue that education throughout their treatment. A lot of patients now look at those portals and know the information before they even come and see us. And so to be able to give them a little bit of education about what they're looking at, I think is very helpful.
Absolutely. And about those portals, I remember when the portal and the tumor marker, we had to sort of reckoning of people seeing their tumor markers, their monitoring biomarkers before even we did, or we had a chance to talk to them. And so again, it was just the right thing to do, giving patients access to that information as that healthcare data. And so they deserve to have that access. But exactly as you just said, giving them that education ahead of time. So if you see your numbers and they do this, please call me. Let's talk about it. Giving them the information they need so that they are aware that sometimes they're going to see it before even we've seen it or we maybe have a plan of what comes next. And so I think that opened up a whole different landscape of this part of care of just trying to be able to proactively prepare patients for what they might see and then kind of what comes next from there.
Patients haven't never really looked at their lab counts before. They may look at their cholesterol. They may look at what their hemoglobin is because they've heard that that's something they should look at. But before they got cancer treatment, they didn't look at neutrophils. They didn't look at every little piece of the electrolytes. They looked at the important things that they thought they may have to take medications on. So maybe a glucose even. So I think it's really important, again, to look at those first ones with them and say, these are what your normal ones are. This is what we should expect to see when you're getting treatment.
And as you said, online, there's red arrows, there's up and down, there's exclamation points. Like it kind of look a little scary if it's not all like the black normal color. And so I think part of that also is letting them know, like, this might not ever look completely normal. And a lot of things might be a little bit out of range, a little bit high, a little bit low, and it's nothing that we will panic about and probably nothing that we will do anything about. It's those extremes and those certain values that we're watching. And so I agree, the more we can educate patients and their families of kind of what to expect and prepare them with that information will probably help them feel just a little bit more comfortable about what's happening.
I've been an oncology nurse for a long time, so I know oncology normals. I don't know normal normals anymore. So looking at like my son's labs or other people's labs, I'm like, oh, your labs look great. Oh yeah, that's because those are normal labs, Clara,
Oh, right.
not oncology normal. We fall into those, like we know what's normal because we look at it every day, but the patients may not know what's normal. And all of a sudden there's these red or arrows, down arrows, and they're freaking out. And it's like, no, that's normal oncology. That's what I would expect to see. So again, just that education of what the new oncology normal is for them.
I have memories of getting that critical call from lab on, Mr. Jones's platelets of 15. And we're like, hey, that's better than yesterday. That's not bad. Like you said, it's sort of like it's relative in our world. So that is important for us to remember as well as, as we educate our patients. So great advice.
A neutrophil over 1,000, you're like, what?
Hey.
I've never seen that before.
Outstanding. Absolutely. Well, Clara, thank you so much for joining us today on the podcast. Lots of great information. It's always great to go back to basics and just kind of talk through things. You've been a nurse for a long time. If you've been in oncology for a long time, these things just become, you just know it. But it is good to kind of peel back a little bit and just remind ourselves of when we first learned this, what did we know about it? And this has been really helpful. As we approach the end of our podcast, we always like to wrap up with a quick series of some quick fire questions. And so we'll start that off now. How do you think healthcare professionals can evaluate their hidden or their implicit bias when it comes to monitoring patient labs?
The only thing in patient labs where you see hidden implicit bias is really with your GFR, because it does look at race. And I think there is some research out there that's trying to get rid of that. Race and gender is something you look at with that. And as we know, not everybody identifies with the gender that they were born with. And so that kind of plays a part in how you look at that. So just making sure that we continue to monitor the research because they are looking to see if we can get rid of that. There is some saying that African Americans have a higher GFR because of race, but now the research is really showing that's not there. So I think we're going to continue to see that change in the landscape. But other than that, labs are labs. It's how your body is adjusting to what's going on within itself.
Absolutely. And I'm so glad you mentioned that. That is an interesting development that we all should keep our eyes on for sure. What are some common misconceptions about lab tests and results in patients with cancer?
Again, there's oncology normal, right? I think that's a misconception. I don't know normal lab values anymore. I already stated that because I'm so used to seeing oncology normal. But as we are seeing newer treatments come out, targeted therapies, we're seeing BiTE therapies, we're seeing immunotherapies, the lab values are changing a little bit. And that landscape of what the new normal is for our patients is changing. So again, it's just really learning as these new agents come out, what we need to be looking for in those patients.
So true. What's something about this topic that's not often discussed, but you wish people knew more about?
I would say pregnancy testing. I don't think that's discussed a lot. I think people know it's the right thing to do, but at our organization, before we started the policy where everybody got it, it was the physician's responsibility to have a conversation with the patient. And I think that is doing a disservice to our patients and their future children, if that's what they're trying to have. And so I think pregnancy testing is one of those things that people just don't really talk about a lot.
What additional training or education do oncology nurses need to help them monitor and educate patients about lab tests and results?
I think most of this we got when we were in nursing school, which seemed like forever ago for me now. But I think it's just important to just always remind yourself, if you're not sure what a lab value is, look it up. A quick Google search can tell you what a creatinine is. It can tell you what the normal values are. It can tell you how to look at different things. So I think it's just really, again, just continually learning about the different things that we're looking at every day with our patients.
And what are some additional resources for maybe other healthcare professionals or patients who want to learn more about lab results?
I'm going to be honest, I Googled some of this stuff just to help me remember exactly everything I needed to say. The NIH and NCI has a lot of resources for patients, as well as the American Cancer Society on blood counts and what you should be looking for. So again, using those resources that are out there. ONS, the chemoimmuno book goes over all of that really well. It's a great resource as well. There's a lot of great resources out there to help you learn more and to help your patients learn more.
Well, Clara, thank you again. It's been a great discussion today. I know that I've remembered some things that I am sure I learned at some point, but now I remember again. So thank you so much for your time. Do you have any final comments to share with our listeners?
Thank you for letting me share this wisdom with you today. And again, it helped me remember some things that I had forgotten as well over the years, but making sure that our patients are aware what the lab counts are, and especially with portals, making sure that they're educated early on about what they should be looking for, I think is important to remember.
Wonderful. Thank you so much, Clara.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.